All right, class, today we're diving into the building blocks of pathology terminology. Ever notice how many medical terms start or end with specific prefixes or suffixes? It's like learning a whole new language, and understanding these components is essential to really grasp what we're looking at under the microscope.
Wow. So it's not just random words? I mean, how does knowing hist or micro actually help me in a real case?
Great question. Let's take hist. It means tissue. So when you see histology, it's literally the study of tissues. Same with microtype. That means small. So microscope is literally a tool for looking at small things, usually tissues or cells. And macro is the opposite. It means large. So macroscopic refers to things visible to the naked eye.
So you're saying that by understanding these prefixes, I can actually tell what a term means just by looking at it? That's kind of amazing.
Um, exactly. It's like having a shortcut to understanding. Take hyper T, that means above or beyond. So hyperchromatic refers to cells that are darker than normal, a key feature in some cancers. And hypo is the opposite. It means under or below. So hypopharynx would be the part of the throat below the voice box.
Wait. So if I see hypo, I should be thinking under or below. That makes sense. Probably. But what about terms like Leo or Myo?
Good catch. Leo refers to smooth muscle. So leiomyoma would be a benign tumor made from smooth muscle. And myo is similar, but it can refer to muscle in general. Now let's look at this image to see how these terms might appear in actual tissue.
Looking at the slide, I can see cells that look like they're made of muscle. Does that relate to the terms we just discussed?
And it was sound. This is a slide showing smooth muscle cells. That's what Leo refers to. Now let's look at the patterns. For example, alveolar refers to a cluster of cells that look like little pockets, like air sacs. You can see that in this image labeled alveolar pattern.
So alveolar is like those little pockets and looking at the other patterns, cribriform seems like holes in a sieve. And that makes sense for adenoid cystic carcinoma.
Perfect. And fascicular refers to bundles or strands of tissue, like in this leiomyoma slide showing fascicular patterns. Each of these terms helps us describe what we're seeing in the tissue, making it easier to diagnose.
This is really helping. But what about terms like basiloid or epithelioid?
Great questions. Basiloid refers to cells that look like they're from the base layer of the skin or epithelium. You can see that in the basal cell carcinoma slide. And epithelioid refers to cells that look like epithelial cells, even if they're not actually from an epithelial tissue.
So Epithelioid cells might look like skin cells, but come from somewhere else. That makes sense. What about terms like micro or mega?
Yes. Micro means small. So microscopic refers to things only visible under a microscope, and mega means very large, like mega karyocyte, big cell involved in blood clotting. And these prefixes help us scale our observations, whether we're looking at the big picture or uh, the tiny details. Um,
This is incredible. So, by understanding these prefixes and suffixes, I can actually start piecing together what I'm seeing in the slides without having to memorize every single term.
it would be exactly. It's like learning the grammar of pathology. And as you know, the ability to speak this language is essential if you want to really understand what's happening under the microscope. Um, Now, let's put it all together and look at some more examples. All right, class, let's dive into cellular morphology. We're looking at how cancer cells look compared to normal cells. And it's crucial because the appearance often tells us about the origin and behavior of the tumor.
Okay. So, cellular morphology, like how the cells look under the microscope.
Uh, exactly. Terms like alveolar describe cells resembling tiny sacs or nests like alveoli in the lungs. Figure 2.1a shows paraganglioma that's often described as blue and nested.
Wait, so nested means there's structure but no glands or ducts. Like it's organized but not typical.
Perfect summary. Basaloid cells look like basal cell carcinoma with tightly packed nuclei. Basal cell carcinomas are often described as having a palisading border around the nests.
So biphasic means two types of cells, like spindled cells with islands of epithelial cells.
Spot on. Synovial sarcoma is a classic example. Cribriform refers to a perforated appearance, like a colander, often seen in adenoid cystic carcinoma.
Okay, so it's like holes in the structure. And discohesive means cell falling apart with no borders.
Um, yes, that's lobular carcinoma in situ. Um, now let's switch gears to prefixes and suffixes. Myxo means mucus, like in myxoid neoplasia.
So myxoid just means it looks watery or gelatinous.
Um, exactly. Oid means resembling, but not exactly the same, like sarcomatoid carcinoma. Oma just means tumor or mass, like hemangioma.
Huh? So oma is just a suffix meaning tumor? Okay, got it. What about osseous?
Osis indicates a pathological state like diverticulosis or osteophyte. Um, Tomy means to cut, like laparotomy.
So plasia means growth or proliferation, like hyperplasia.
Correct. And rhabdomio refers to skeletal muscle like rhabdomyosarcoma. And tricho is for hair, like tricho-BZR.
Okay, so we're looking at the interface with normal tissue too. Terms like circumscribed and encapsulated.
Yes, circumscribed means well-defined borders like fibroadenoma. Um, Encapsulated means surrounded by a capsule, like follicular adenoma.
And infiltrative has no clear border, like prostate carcinoma.
Uh, and Lobular refers to uh, architecture like lobular capillary hemangioma.
What about cellularity and mitotic rate?
Cellularity refers to how crowded the cells are or how blue they look. High cellularity often means aggressive tumors.
So, putting it all together, the way cancer cells look under the microscope gives us clues about their origin, behavior, and how aggressive they might be.
Um, Absolutely. Morphology is key to diagnosis and understanding the tumor. All right, class, let's dive into chapter 2. Today we're talking about descriptive terms in anatomic pathology, specifically histological patterns. These patterns help us classify tumors and understand their behavior.
So, histological patterns are like blueprints for different cancers. That sounds important.
Exactly, and take this first one, figure 2.1. Alveolar pattern, paraganglioma. Think of it like Swiss cheese, lots of holes. These tumors have a distinct pattern with spaces between cells, which is characteristic of paragangliomas.
Wait, why is that important? Does it affect how we treat the cancer?
Great question. The alveolar pattern helps us differentiate paraganglioma from other tumors. It's a key diagnostic feature. Let's move on to the next one. Here's the basiloid pattern and palisading associated with basal cell carcinoma. Basiloid means the cells look like they're from the basal layer of the epidermis. And palisading refers to those neatly aligned tumor cells.
So, you mean the cells are lined up like soldiers? That sounds organized, but is it a good or bad thing?
Neither really. It's just a descriptor. This pattern is crucial for diagnosing basal cell carcinoma, especially in tricky cases. See the next pattern. Cribriform pattern adenoid cystic carcinoma. Cribriform means little sieve. Imagine a pattern with holes and islands of cells like a colander.
I've seen that term before, cribriform reabsorption in kidneys. Is similar here.
Similar idea, but specific to pathology. The cribriform pattern in adenoid cystic carcinoma is a hallmark feature. It helps us distinguish it from other tumors. Epithelioid cells, breast carcinoma. Epithelioid means the cells look like epithelial cells round with distinct borders. Breast cancers can have this pattern.
So, epithelioid just means the cells look normal-ish. But in breast cancer, that might not be good news.
Not necessarily. Epithelioid cells can be seen in many tumors, but in breast cancer, it often points to certain subtypes. Let's move on. Fascicular pattern, leiomyoma. Fascicular means bundles or strands. Think of parallel rows of muscle cells, like bundles of fibers.
So it's like those muscle bundles in a rope. That makes sense for a leiomyoma, which is a muscle tumor.
And if the fascicular pattern is characteristic of benign leiomyomas, it helps differentiate them from malignant counterparts. Herringbone pattern fibrosarcoma. Herringbone looks like a fishbone pattern with cells arranged in a wavy zigzag pattern.
That sounds painful to look at. Is this pattern common in other tumors too?
Not really. It's more specific to certain sarcomas like fibrosarcoma. It's a key feature for diagnosis. Hobnailed cells, angiosarcoma. Hobnailed means the cells have a distinct projection, like a little nail. Think of them as cells with a petal or stalk.
So they look like little hobbits. Hobnailed cells? That's
oddly.
It's a memorable way to think about it. Hobnailed cells are characteristic of angiosarcoma, especially the spindle cell type, microcystic pattern, mammary analog secretory carcinoma. Micro means small, cystic means blisters. So lots of tiny cysts in the tumor.
This one sounds similar to some breast cancers. How is it different?
Mammary analog secretory carcinoma has this specific microcystic pattern along with other features. It's a subtype of carcinoma with a better prognosis than some others. Last one for today, micropapillary architecture, serous carcinoma of the ovary. Micropapillary means tiny finger-like projections. These are very small compared to regular papillary structures.
So it's like the papillary type, but on a microscopic scale. And this is a type of ovarian cancer.
Yes. And it's an aggressive subtype of serous carcinoma. The micropapillary pattern is a poor prognostic factor. All right, class, let's talk about some classic architectural patterns and key diagnostic features you'll encounter in surgical pathology. We're looking at figure 2.2 from the text, which shows classic examples of each pattern.
Okay, so this is a slide comparing different tissue patterns. What makes each one distinct?
Is mix. Let's start with A. Do you see the branching finger-like projections? Does allow us all exposed to, they have actually foot propaganding in.
So you're saying that the shape of the cells tells us what kind of tumor it is. That makes sense.
Good observation. Now look at B. These are tumor cells arranged in a network of thin walls. That's the reticular pattern. Classic for yolk sac tumors.
Wait, is that important for diagnosis? Or just a characteristic feature?
It's both. The reticular pattern is highly suggestive of yolk sac tumor, especially in the testis. It's sort of a key diagnostic clue that
Okay, so different patterns point to different tumors. See what else is here.
here we have rosettes, cells arranged in a target-like pattern around a central lumen. This is typical of ependymomas, which are tumors of the spinal cord.
So you're saying that the shape of the cells is just as important as their arrangement?
Absolutely. The specific arrangement helps us distinguish ependymomas from other neural tumors with similar cell types. Next up, staghorn vessels. These branching antler-like blood vessels are characteristic of hemangiopericytoma, a rare soft tissue tumor.
So you're saying the blood vessels themselves look like antlers? That's pretty specific.
Correct. Look at this storiform pattern, where spindle cells are arranged in layers or arcs resembling a Swiss roll, is classic for dermatofibrosarcoma protuberans.
Okay, so the arrangement tells us a lot about the tissue of origin.
And then after the table, for F, nodular fasciitis shows cells forming distinct benign-looking nodules, very different from the malignant patterns we might see elsewhere. Here's G. Notice the uniform cells with pale granular cytoplasm. That's the oncocytic pattern key for diagnosing oncocytomas.
So the cytoplasm looks different, like it's packed with mitochondria or something.
You picked up on that. Yes, the abundant pale cytoplasm is due to lipid and glycogen storage, and it's a hallmark feature. Moving on to necrosis. H shows coagulative necrosis, the classic ischemic pattern where tissue architecture is preserved, but cells are damaged.
So it's like the structure is still there, but the cells are messed up.
Exactly. And think of it like boiling an egg, and the shape is preserved, but the contents had changed. And common in heart attacks or severe infections. And finally, this caseating necrosis seen in tuberculosis granulomas is different. Notice the central area looks like cheesy, crumbling tissue.
That's the key difference from coagulative necrosis. The actual breakdown of the tissue.
You got it. Caseation represents more advanced tissue breakdown, often seen in infections like TB. It's crucial for making the right diagnosis. Great. Let's dive into some fascinating pathology examples. Look closely at these different types of necrosis and cellular changes. They're crucial diagnostic clues.
Wow, these look quite distinct. What's with all these different kinds of tissue damage?
It's such a question about your. This slide shows examples like fibrinoid necrosis in the pulmonary vessel. fat necrosis in breast tissue and gangrenous necrosis in a toe wound. And each tells a unique story about what happened to the tissue.
Wait, why is that important? Can't we just tell what's wrong with the tissue by looking at it generally?
Um, that's a great question. Um, the specific type of necrosis often points directly to the underlying cause or the type of disease process. Um, but let's not forget, pathology isn't just about damage. We also look at what's still functional or abnormal in the living cells.
Okay, looking at this, I see lots of purple and pink areas. What's going on there?
Excellent observation. Remember the H in H&E? Hematoxylin stains the nuclei purple because it targets the nucleic acids inside them. Eosin highlights everything else in the cell, cytoplasm, extracellular matrix. This staining pattern is fundamental to pathology.
So you're saying the purple stuff is always the nucleus. That would be really helpful to know.
Precisely being able to identify nuclei is a core skill in pathology. You spend years learning to recognize subtle changes in nuclei like the amphiphilic cytoplasm and pheochromocytoma, foamy macrophages in renal cancer, keratin deposits in squamous cell carcinoma.
That's a lot to remember. How do you actually see these differences?
Through the microscope, of course. The H&E stain provides that beautiful contrast between the purple stained nuclei and the pink stained cytoplasm and background. And it's the foundation for almost all microscopic pathology diagnosis.
Okay, I think I get it now. So these specific patterns, whether it's the type of cell death or the appearance of the cells themselves, are key diagnostic features.
Absolutely. That's why mastering H&E stained tissue is essential for a pathologist. It's the language we use to describe what's happening at a microscopic level. Keep practicing those observations. All right, let's talk about atypia. It's a term we pathologists use frequently, but it's crucial to understand its nuances. And the key is to minimize the use of atypical in your diagnoses. Variants include reactive atypia, degenerative atypia, marked atypia, and milled atypia.
So you're saying that using the term atypical should be avoided unless absolutely necessary? That sounds important. Why is that?
Exactly. I think let's break it down. Reactive atypia refers to nuclear changes that might concern me, but only if it weren't for this blazing inflammation. Degenerative atypia would concern me, but only if I wasn't 100% sure this was a benign tumor. Marked atypia is more, or marked atypia is more pronounced. Almost certainly cancer. But remember, I'm not liable if it turns out to be reactive atypia instead. And mild atypia is so trivial, almost certainly benign. But again, no suing me if it's actually dysplasia.
Wait. So in each case, the severity of the nuclear changes is contextualized by other factors, like inflammation or the certainty of a benign tumor?
It's about the bigger picture. Always consider the surrounding tissue and other features. Pathology isn't just about nuclear changes. It's about understanding the whole slide.
Got it. So the key takeaway is to look beyond the nucleus and consider the context, right? To
You're looking at a slide of tissue, right? And you see nuclei. But just because you see a nucleus doesn't mean it's part of the tumor. The problem is all these variables, fixation, staining, crush, can drastically change how those nuclei look.
wait, why is that important? Doesn't the tumor itself cause changes?
Exactly. The same tumor can look completely different depending on how it was prepared. So part of learning pathology is figuring out which nuclear features are truly indicative of cancer and which are just artifacts.
So you mean there's no single correct way to see it?
Right? And which brings us to calibration. Think about how your brain learns to identify colors. You see blue under different lighting, right? But your brain knows blue isn't always the same wavelength of light. It uses other objects as references. Similarly, in pathology, you use the non-tumor nuclei as your reference point. If you see a nucleus that looks different than the normal cells around it, you suspect it might be an artifact.
So comparing the tumor nuclei to the normal ones is like comparing the color of the object to the color of the reference paper.
Exactly. It's about understanding that the raw signal we're seeing isn't always the true picture. Uh, we need to calibrate using what we know is normal.
Okay. So the key takeaway is always compare tumor nuclei to non-tumor nuclei to determine what's truly abnormal versus what's just an artifact.
And remember, this isn't just about one feature. It's about the pattern, comparing the overall appearance of the tumor cells to the normal reference. All right, class, let's dive into the fascinating world of nuclear artifacts. One key thing to look for are signatures that are specific to certain tumor types. For example, take papillary thyroid carcinoma. It often features a very distinctive pattern.
Papillary thyroid carcinoma. Is that the one with the characteristic clearing?
Exactly. So you've got it. The cleared out chromatin creates that signature appearance. Now, another feature we see is testicular nuclei. These are large round nuclei with minimal chromatin.
Wait, so vesicular nuclei are associated with malignancy, but you said they can also be a consequence of delayed fixation. Is that right?
Correct. It's a classic point, and vesicular nuclei can be seen in malignant tumors, but they can also appear if the tissue wasn't fixed properly right after removal. So we have to be careful with that. Now, let's talk about the general categories of nuclear changes you should recognize. Among the most telling are large and hyperchromatic nuclei. And these indicates chromatin instability, literally too much chromatin, and are often seen in malignancies.
Hyperchromatic means dark staining, right? So the nucleus has a lot of tightly packed chromatin?
Exactly. That's a key feature. Now, contrast that with large but euchromatic nuclei. These have loosely staining chromatin. They're commonly seen in benign reactive cells. And finally, irregular nuclear membranes, folds, crenations, corners, asymmetry. These are almost always absent in benign cells. And they're a strong indicator of malignancy.
So to summarize, we're looking for specific nuclear features like cleared chromatin and papillary thyroid, vesicular nuclei with caution for fixation artifacts, hyperchromasia for instability, and irregular membranes for malignancy. Got it.
Perfect summary. Remember, these are general categories, but always look for the specific signatures that point to a particular tumor type. All right, class, let's talk about the nucleolus. It's a structure within the nucleus, and its appearance can tell us a lot about the cell's activity and health.
Really? I thought the nucleus was pretty standard. What kind of information can the nucleolus give us?
Well, a prominent nucleolus indicates an active nucleus, meaning the cell is probably synthesizing a lot of proteins, but don't jump to conclusions. A prominent nucleolus doesn't automatically mean the cell is cancerous.
Wait, why is that important? Like, what are some examples of normal cells with prominent nucleoli?
For example, normal myeloid blasts, those are immature blood cells, have prominent nucleoli. And reactive epithelial cells, which are cells lining organs that respond to injury or infection, often have multiple small nucleoli.
Okay, so sometimes nucleoli are normal, but when would it be a sign of something bad?
That's a great question. And the presence of a large and reddish nucleolus, which is protein rich, in a tumor cell is characteristic of certain tumor types. We're talking about carcinomas, melanomas, angiosarcomas, and some lymphomas like Hodgkin lymphoma.
So that specific size and color are key. What about other patterns?
Yes, and then we have neuroendocrine tumors. These typically have very finely speckled chromatin, and interestingly, they usually don't show a prominent nucleolus at all.
Neuroendocrine tumors. I remember they're aggressive. And what about cells that seem less developed?
It's still a lot that really primitive cells, like those found in small round blue cell tumors or fetal cells, have a characteristic homogeneous dispersed blue chromatin. It's like the cell hasn't differentiated yet, and has all its genes spread out evenly as if it's waiting to organize them.
Okay, so summarizing, the nucleolus gives us clues about cell activity, but its appearance alone isn't enough to diagnose cancer. Different cell types have different patterns, and sometimes the lack of a specific feature is just as telling.
That's a good way to put it. and remember microscopic details like nucleolar size, shape, and color, and along with the overall chromatin pattern, help us classify cells and understand what's going on at a molecular level. As a pathologist, you'll inevitably start to anthropomorphize individual cells. This isn't unusual, far from it.
Anthropomorphize cells, like giving them human traits or emotions? That sounds weird.
Exactly. You might start thinking of certain cells as stubborn or rebellious because they're resisting apoptosis, or perhaps seeing them as cowards for avoiding contact with other healthy cells. It's a coping mechanism, really.
Wait, so you're saying that pathologists develop emotional connections to cells? That's unsettling.
It's not unsettling, it's practical. It helps you remember their behavior patterns, and it's not atypical. In fact, it's often how we distinguish between different subtypes of cancer cells. One cell might be lazy, another aggressive, and their interactions tell us a lot about the disease.
Okay, so you're saying this anthropomorphizing helps with diagnosis. Like, if a cell is stubborn about dying, it might be cancerous.
Precisely. That's a way to remember cellular behavior patterns. But we must be careful. The goal is to understand the underlying biological mechanisms, not just assign personality traits. The stubbornness is actually evasion of programmed cell death, a key feature of malignant transformation.
So it's a mental shorthand, like a mnemonic device, but for complex biological processes.
Exactly. It helps build a mental picture of the tissue microenvironment. The cells aren't just being naughty, they're signaling dysregulation in critical pathways. Um, but the anthropomorphizing helps us remember the behavior that signals trouble.
I see. So it's like using personification to remember specific cell behaviors that indicate disease.
Um, yes, and it helps build rapport with the characters in the tissue. Understanding their personalities helps predict how they might behave or interact with neighboring cells.
Okay, so anthropomorphizing isn't just a quirk, it's a practical tool for remembering cell behavior patterns.
Um, it is, along with other descriptive terms we'll cover, it helps you build a rich vocabulary and mental model of the tissue you're examining. Um, it's part of the pathologist toolkit. All right, class, let's dive into some fascinating nuclear characteristics. We're looking at specific adjectives that describe how cell nuclei look under the microscope. Uh, these can be crucial for diagnosis, especially in pathology. Uh,
Nuclear adjectives, like descriptive terms. Okay, that makes sense. What's the first one?
the first is clock face. Imagine a soccer ball when chromatin is evenly distributed and clumped. It looks like clock faces on a soccer ball. This is often seen in certain plasma cells.
Wait, why is that important? Does it tell us something specific about the cell or the disease?
Um, good question. It's often associated with specific plasma cells, which can be significant in certain lymphoproliferative disorders. The uniformity suggests a particular stage or type of cell maturation.
Okay. Got it. So, eccentric then. What does that mean?
Exactly. Eccentric means the nucleus is displaced to one side. You see the nucleus on one side and the cytoplasm on the other. And this is characteristic of plasma cells and rhabdoid cells.
Eccentric versus plaque face, both related to plasma cells. How are they different?
Great observation. Clock face describes the appearance of the chromatin within the nucleus, evenly distributed clumps, while eccentric describes the position of the nucleus within the cytoplasm. They describe different aspects.
Okay. Differentiating appearance and position. Got it? Next one is molding.
But in fact, this molding refers to nuclei that press together and indent each other due to a near absence of cytoplasm. It looks like a mosaic pattern and is often seen alongside small, dense blue nuclei. Think small cell carcinoma.
Molding because they press together. So the cytoplasm is minimal, forcing the nuclei close. And the mosaic look comes from the arrangement. Okay? What about neuroendocrine?
Yeah. And neuroendocrine nuclei have a specific chromatin pattern. Finely speckled or salt and pepper. They're similar, round, pale, smooth, without nucleoli, but you might see occasional chromatin chunks or speckles. Think carcinoid tumors.
So, no nucleoli, but some speckles. Is the salt and pepper just a way to describe the speckled chromatin?
Precisely. The absence of nucleoli and the specific speckled chromatin pattern are key diagnostic features. It helps differentiate neuroendocrine tumors from other entities.
Okay, so pleomorphic then, multiple sizes and shapes.
Exactly. This pleomorphic means multiple shapes and sizes. It implies a very irregular mix, often seen in embryonal carcinoma from the testis.
Okay, so very irregular. Last one, vesicular.
Yes. Vesicular describes a nucleus, an open phase, where the chromatin is expanded, not compact. It looks swollen and distorted by bubbles in the chromatin. This is often seen in various malignant neoplasms. And that's a wrap. These nuclear adjectives are powerful tools for describing and diagnosing cellular changes. All right, let's dive into some classic pathological associations that often help guide our diagnosis. The first one is neuroendocrine nuclei and carcinoid tumors.
Oh, so when we see neuroendocrine nuclei, it often points us toward a carcinoid tumor?
Exactly. Carcinoid tumors, especially in the gastrointestinal tract, frequently show these distinct neuroendocrine nuclei. It's a key feature to look for.
Like, why is that important? Does it change how we treat the tumor?
Yes, definitely. Uh, it helps differentiate carcinoid tumors from other types of neuroendocrine tumors or carcinomas, which have different prognoses and treatment approaches. Moving on, the next association is a cherry red nucleolus and melanoma.
So, a cherry red nucleolus is a sign of melanoma. That sounds pretty specific.
Indeed. This feature, often called the cherry red or a poppy red nucleolus, is a classic finding in melanoma cells, especially in metastatic deposits or in certain primary lesions.
Okay, so it's a red flag for aggressive behavior in melanoma?
Correct. Also, it's one of those telltale signs that can help us confirm a diagnosis when combined with other features like the presence of melanin. And next up is myxoid stroma and myxofibrosarcoma.
Myxoid stroma, like the stuff you see in myxoid tumors. And myxofibrosarcoma is a type of soft tissue sarcoma, right?
Exactly. Uh, Myxofibrosarcoma is defined by its myxoid stroma, which gives the tumor its gelatinous mucinous appearance under the microscope.
So if we see a soft tissue mass with this feature, we're thinking sarcoma.
Yes, and it's often associated with a specific gene mutation called WWTR1 CANT2N3, which we might explore further if this finding is present. Next, we have desmoplastic stroma and colon cancer.
Desmoplastic, like fibrous tissue. So in colon cancer, this stroma is reactive to the tumor.
Yes, that's right. Desmoplasia is a common feature in many cancers, including colon cancer. It's the tumor's way of evading immune destruction by creating this dense fibrous environment.
So it's not just the cancer cells themselves, but also the reaction to them.
Precisely. And in some cases, like pancreatic cancer, desmoplastic reaction can be so prominent that it's almost diagnostic. Now, hyaline deposits and vessels in schwannoma.
Schwannomas are nerve sheath tumors, right? So hyaline deposits and vessels are part of their growth.
Yeah. These tumors often show areas of hyalinization and vascular proliferation, which can sometimes mimic other conditions. So it's good to recognize this pattern.
And finally, hemosiderin in nasal polyps.
Yes, hemosiderin deposits can be seen in nasal polyps, often as a result of chronic inflammation or minor bleeding within the polyp.
So it's just a marker of inflammation, not necessarily a sign of something worse.
Exactly. It's a helpful clue, but not diagnostic on its own. We've always need to look at the bigger picture in pathology. All right, let's dive into some T-descriptive terms and anatomic pathology. First up, amyloid. This is a protein that deposits in a specific beta-pleated sheet molecular structure. What's fascinating is its appearance on H&E stain. It looks glassy pink, stains salmon pink with Congo red, and fluoresces apple green under polarized light.
Right, the fluorescence part, that's important. And how does that help in diagnosis?
Absolutely both. The apple green birefringence under polarized light is a classic diagnostic clue for amyloid. It confirms the beta-pleated sheet structure, which is unique to this protein. Think of it as a molecular fingerprint.
Okay, so it's not just about the color, but the specific staining pattern. What other deposits share similar appearances?
Good question. Let's look at medullary carcinoma of the thyroid. Its amyloid deposits are very black and very dense, fine granules, and that's quite distinct from the salmon pink amyloid we just discussed.
And anthracotic pigment probably can't go to this. That's from coal dust, right? The description says it's very black and very dense, fine granules. That makes sense for something inhaled over time.
And exactly, it's a form of pigment-laden macrophage. Now, let's contrast that with calcium and Sonoma bodies. These are purple and granular with hard edges. Sonoma bodies in particular are concentrically laminated.
So, the hard edges and concentric layers help differentiate it from other calcifications. What about Samoma bodies in other contexts?
Salmon.
They're classic in certain tumors like papillary thyroid carcinoma or some carcinomas of the breast. Now let's move on to colloid. In the thyroid, colloid refers to that pink substance in the follicles, which is mucin-like.
Mucin-producing neoplasms also get called colloid, right? So the term is used broadly there.
Yes, that's correct. Now, hemosiderin is another pigment. It has a glittery golden brown refractal appearance, especially when using the poor man's polarizer, like waving your finger above the light source.
So that's old blood breaking down. And it's visible under polarized light.
Exactly, and it's a breakdown product of hemoglobin. Then we have lipofuscin, which appears yellowish brown and globular, often seen in things like seminal vesicle.
Lipofuscin is also called the age pigment, right? Because it accumulates in aging cells.
Yes, that's one of its characteristics. Now, melanin is quite different. It's not refractile, and it can range from brown to gray, classic in melanoma.
And tattoo pigment is similar to anthracotic pigment, maybe multicolored. Got it.
Correct. Now let's talk about non-cellular entities. The nucleolus can appear cherry red, implying a malignant-looking nucleolus due to increased protein content.
So a large solid nucleolus with a refractal red tinge is suspicious for malignancy?
Yes, it's often a marker for aggressive tumors. Now, cell membrane features, cilia give a characteristic appearance, and if not visible, sometimes intercellular bridges, desmosomes, are used.
Desmosomes look like prickles between squamous cells. That's visible, especially in edematous skin.
Um, now, stromal terms. Chondroid means resembling cartilage, so bluish gray with lacunae. Desmoplastic refers to edema and fibrosis around a neoplasm. Edematous stroma looks waterlogged with clear spaces because water clears out on H&E stain.
And fibrotic or sclerotic means replaced by collagen, which is pink and opaque.
Yes. Hyaline means clear, transparent, homogeneous, like in vessels and schwannoma. Myxoid looks like mucus with hyaluronic acid, faint pink to bluish gray, stringy.
And finally, colloid and thyroid is a thin, homogeneous pink substance.
Right. So we've covered a range of descriptive terms that help pathologists identify cellular and non-cellular changes in tissue.